So I have the great honor of introducing another close collaborator and very important person in this industry. Steve Thorne is one of the founders of DSOs and the ADSO, scaling nearly 1,000 practices across over 25 states. He's incredibly giving with his time, serving on 2 dental school boards, one of which is with myself and Dean Shaza here from HPU. I most admire Steve because he identifies, uses, and invests in dental technology. He's the whole package when it comes to dental tech. He's the industry's biggest supporter of the mouth-body connection as well as medical dental integration, and he and I are going to get into that in just a moment. And he's been a mentor to me. He often praises me for sounding like a real finance guy. And coming from a clinical dental background, that really is a huge compliment coming from Steve in particular. And I'm going to return a little bit of that favor as I have the opportunity to here for a second. Where if you didn't know Steve for the business accolades, accomplishments that he has so clearly had and impact he's had in this industry, you might just say, he sounds a bit like a dentist. He could fool you. He speaks like a dentist. He can speak to dentists, but he can both talk the talk and walk the walk. So without further ado, Steve Thorne. Testing here.
Thank you.
So Steve and I are going to do a fireside chat, and I want to start this off in a couple of different ways. First of all, we did prepare for this, I want you to know. But Steve and I talk a lot, as you might imagine, about dental technology, the DSO industry, and so many other trends. So what I think is probably most useful to this audience, what I've always wished we could sometimes do, is just talk as we normally talk, but give everybody a view into how those conversations just conversationally work. So we're going to try to be as organic and conversational as we can here and give you bird's eye view into the things that we talk about. In addition to that, we're going to start fairly specific with some different, very specific technology investments and applications. We're going to go broad to where the future of dentistry is going. I'm going to start this conversation with an anecdote. Steve, I was speaking to somebody in the industry this week. They know who you are, just by name, and some of your accomplishments. And, I thought they knew your background and your role specifically, but they know more of your social presence, your LinkedIn posts, and a lot of the content you speak of. And so I said, I'll be sitting down later this week with who needs PDS help. And the person squinted and looked at me back, and they said, "Wait, do you mean the microbiologist?" And Steve, what the confusion is with this person is they saw so many posts on the different forms of salivary diagnostics and P. gingivalis and bacteria in the mouth that obviously they got your role wrong and I won't help this person in the industry, but I think it gives a lot of credit to the areas that you're focusing on the most and some of the things that are most important in clinical care right now. So with that, let's segue into the fact that you, Steve, and also PDS Health have really put a lot of chips on saliva. Salivary diagnostics, saliva as the liquid gold, technologies that do that. Tell us about that. Why saliva?
Is it working? No? Yes. No serious clinician disputes the mouth-body connection anymore. And the root of, I think, a lot of that is saliva. We swallow about 1 liter of saliva every single day. And that saliva is filled with all sorts of stuff. And good stuff and bad stuff, right? Speaking to a dentist. And, some of my mentors and teachers in the room who know way more about this than I do. But that saliva tends to get worse as we get older because our oral health gets worse as we get older. And so I believe that saliva will be SOP, standard procedure, for every dentist practicing in the future. And we're not talking 10 years out. We're talking a year or two. We've been tracking this live companies, right, together.
We got a lot of work together.
And last year we were tracking 13 saliva companies in the United States trying to break through to point-of-care saliva testing.
About 26 globally, if we expand it.
Okay, last year.
Last year.
We're tracking 24 now in the United States, trying to break through to bring point-of-care saliva testing to dental practices and primary care physician practices. As all of you know, CMS now probably know, hopefully you know, CMS has now mandated, not mandated, but they have a provision for primary care physicians to get, I guess, paid for in a way, paid for doing oral exams and referring to the dentist. First time in history. I think that change in the CMS provision, if I said the details of it wrong, please excuse me, I don't quite understand all the nuances of how it works. But that little change is game changing for the dental medical integration, right?
It is.
Because it's validating with the CMS and all that goes on with Medicare, Medicaid, and all that, validating the mouth-body connection. And so there's a lot to it, but I think saliva is the base of it.
So, Steve, partly for the fun of it, but also for the educational purpose of this room and this conversation, let's break down, just you and I calling out, some of the things we have found interesting in saliva. I'll start the conversation with obviously pH, right?
pH,
Go to a critical level, you erode teeth.
Right.
Temperature, maybe compliance in the mouth, things going in and out of the mouth, like removable prosthetics.
Right.
What are some of the things you guys are looking at in saliva as well?
Well, so I sort of grew up as a technologist in space. I don't know if everybody knows the history. I'll give real quick. So I started in this industry by putting in a computer system in my dad's dental practice in 1989. And so that was the days of the old IBM XTs, XPs, Nobel networks, green screens, stop matrix printers, those sort of things. Many of you don't, you're too young, you don't even remember. Some of you, I'm looking at gray hair, you know exactly what I'm talking about. So that's where we start. So I've always been very proactive in technology and trying to figure out what's going on. So I think one of the game changers in that evolution for the last 36 years was the use of the intraoral camera. That's when I saw case acceptance materially jump, because patients don't know what the hell they're looking at an x-ray, but they do know what they're looking at on an intraoral camera. Since I've never seen something since then have such a material change in a dentist's productivity, in a patient's engagement, and a patient's activation. I'm really big on engagement and activation into care. Until, and I'm not pitching this, it's just a fact of doing the oral fitness test that we now do. And there's lots of things we can measure with saliva on oral fitness. We happen to choose one, and we measure AMMPA, right?
So a measure of periodontal disease state, or the risk thereof, periodontal disease state.
And current state of your health, of your mouth, that measures collagen breakdown and things like that. If you want to, you can talk to Dr. Ollie over there if you want the technical parts, right? So, but this one assessment has been game changing for patients. They get a score. They go, oh, wow, I'm not as healthy as I thought. Suddenly, they want to learn more. And they activate into care. 36 years, it is the best thing I've ever seen in operations to activate patients into care, as an example. And I think once we get to the real measurements that we can get to, I think it's even going to be better.
Healthcare measurements.
Healthcare measurements, measuring PG, measuring FM, measuring AA, all
these are free bacterial.
All the different bacterial levels.
And certainly you can find carbon monoxide levels or dioxide levels. Showing
Cancer, pre-cancer. I mean, now saliva they're using it for breast cancer and all sorts of things. It's super important.
Diabetic measures.
Diabetic, use A1C.
A1C in the blood. You can now measure, we've invested in a company on kind of the more sports oral health side. So looking at concussion, dehydration, right? You can measure ketones. There's a lot of different areas that can be found in the mouth.
Yeah, so you don't have to get stuck with a needle.
That's right. And it's a number. But I think which is important, what Steve said, is people need a number. There needs to be a numerical thing that tells the person quantitatively and objectively, hey, I'm not where I thought I was. They need to do something.
Right.
Steve, you brought up an important point around activation of, into care, that point of care access, and then activating into another step.
Right.
I'm going to give an example of this. If we do a saliva test on the sideline of a sports event, and you're found to be at risk of concussion or dehydration, there could be a route to care for this person before a bigger problem exists. It sounds like, from your perspective, it's important that these measures happen at chairside, at the point of care. But we do have a lot of measures that are happening that are not on point of care, right? And I'm wondering what you think of this, right? Patients who do a saliva test on their own, and activate in a more consumer channel, or do it at the office, but it's sent off to, a CLIA-approved lab, and then they get a result back later. They can measure different things, lab side, measure chair side.
Right.
What are your thoughts on that compared to the chair side?
Well, on the medical side, it's booming. Right, you get companies like SevoX and Function Health and Biome and other. It's booming, right? And then they get the report back. But then, what does the patient do with that? How many of those activate into care? So, what we're extremely focused on is how do we get the patient to cross the threshold? Meaning, we think the doctor-patient relationship is the key. And we want to do everything we can to enhance that relationship. And so that's why I'm so focused on point of care devices. Now, those other things are good. And there are at-home saliva tests for checking your oral health right now, kind of like a pregnancy test, red-green sort of test. But I just don't know how many patients actually use them and then activate.
That's the question. You guys are very focused on saliva. Obviously, you have a couple of tools chairside. Is there any tracking that either you do or you're going to do or you might recommend others in the room do or could help us enable it from an industry technology side? How do we track if they did do one of these things? They're sitting there
at home?
Yeah. How can we find out from the patient, or how can we work better to get the data?
Well, and we're working on that, but I think the technology's there. So you can take an at-home test, and somehow it could get into your phone with an app, maybe through your camera, right? So it gets in your app, and then if the app can integrate with your EHR, which we're working on, and now you've collected this information for the patient. And then if they do that over time, I think one of the critical things we miss is the longitudinal data here, which we're working on. Several other companies are too, on tracking patients over time, whether it's cracked teeth, whether it's bacteria, whether it's bone loss or whatever. And that's huge for patients. Because if you're coming in over and over and you tell a patient, hey, back 2 years ago you had 60% bone, now you're down to 40% in 2 years. We gotta figure this thing out. So all of that is involved in the things you're investing into, that we're investing in. It's crazy time right now in dentistry, right? In oral health.
Huge proliferation of products.
It's incredible.
Longitudinal data, you said, an important point on the oral health, sort of on the odontogenic or periodontal charting side. Right. But also even on the saliva side, where there's an important distinction technologically there with a spit test, which is good. It's a chairside, quick, fairly cost-effective measure, but it's a snapshot of your mouth at one time.
Snapshot.
Versus there are now some solutions coming to market around continuous monitoring of saliva in the mouth.
You'll put them in your teeth,
wear them, or have them fixed in your mouth.
Right.
Now they're going to show how these things go up and down over a longer period of time, giving us longitudinal salivary data. It's interesting. There's a lot of proliferation of data. Let's touch mouth-body connection here for a second, just go a little bit even broader. in topic. You know, we run a fitness test or we run a panel on saliva. There's a DSO organization in the room, very unique, that runs actually a whole panel of information. You know, sometimes it goes even beyond saliva, in blood or stool or other measures. We get back these measures now. Now here we are sitting as a dentist or a dental practice in the line of primary care. We've just found out critical and new information about the patient. We present it to them, we educate them. How do we activate the rest of their healthcare journey? Really at the end of the day, we can measure maybe on the healthcare side. We can provide dental treatment, but what you guys are doing on the PDS Health side, it goes beyond that. It transcends onto the healthcare model itself. How are you providing care on that side?
Yeah, so it's I'll refer back to the last panel, the deans of the schools and all of that. So I think there's 7, and I think most of you know we switched from Pacific Dental Services. We're now called PDS Health. So we're focused on the dental medical integration, and our nurse practitioners and physicians also do saliva testing also. And I tell you what, when nurse practitioner or physician tells the patient that you need to go see the dentist, it's something really special for the dental side of the business. So all of the business people in here, they show at a much higher rate, they spend a lot more money, and they activate it in care at a much higher rate also when they're referred from the physician or nurse practitioner. We're expanding that into some of the other specialties too, by the way. So gynecology, cardiology, and gastro and others. So it's a real exciting time. How do we do it? We do it through the power of Epic. When one of our clinicians sees a patient, they have so much information right at their fingertips about the patient's overall health. They want to know if they're diabetic. They want to know a family history of cardiovascular disease. They want to know about family history of dementia, Alzheimer's, whatever. We have it, and then we package it up in a neat little image for the clinician and the patient. See, I believe that the clinician and the patient should be looking at the same information at the same time on the screen. And it's super powerful when they're looking at that and they relate these two, that, oh, my mouth is important. Oh, my mouth is part of my overall health. This idea that it's been separated, whoever did that, you know, in the 1860s or whatever it was, right?
In the 1800s.
Yeah. When I get to heaven, I'm going to slap him. Because it's like crazy, absolutely insane that we're separated.
We're going to put a security on that gravestone for sure.
Yeah, but you know, and I come from a family of dentists. So my grandfather graduated Harvard in like 1936, and he practiced 50 years. My father graduated at UOP, former dean is here somewhere, UOP in 1966, and graduated 50 years. 2 of my brothers are dentists. I live dentistry. My main partner is a dentist.
So he does really speak like a dentist.
I've done everything I've actually practiced some dentistry in a different country where I was allowed to. Never in this country.
Let's go ahead and delete the recording.
That was Ethiopia, so go for it. Okay? Where was I going with that?
Statute of limitations.
What?
Statute of limitations.
Yeah, it is statute of limitations. But this whole concept that we as a profession look into a patient's mouth, look at the destruction that's happened, and then fix it has got to change. So the deans in here, the schools, please, and I know some of you are working on it like crazy, right? That concept of looking at the disease, looking at the destruction, looking at what happened, and then fixing it, there will always be a place for it. But we have to get in front of it.
We're reactive.
We're very reactive. And I call it predictive and preventive. We're trying hard to get to the preventive side, and that's hard enough. But the real deal is to get to the predictive side, which we have the technology to do it now, but it's very hard. So back to answering your question, how do we do it? We do it with the power of the electronic health record. I don't believe you can do it with the standard health record out there. You have to have chart reconciliation across across different records. You have to be able to pull that information about a patient coming in from all their various providers, and the gold standard is Epic right now. And that's why schools are, sorry David, that's why schools are switching to Epic all across the United States.
And how do you get so a couple of really important, I think, points are in there. And one of the big ones I want to kind of highlight is what will change your business, what will change the patient's healthcare at the end of the day. It is the clinician, it is the provider, and the patient. It's that bond between them.
Yeah.
The patient ultimately owns that data. So also the trend that we've had in this industry of the data belongs to the vendor or the company, or even to the practice, charging them for printed out papers, right? That is not even legal in today's world, right? It is the patient, and beyond that, we want the patient to own the data and see the connection, because we need them to take action at the end of it. They have to say yes. They're autonomous, right? We need for the patient to say yes. And the other piece on the provider side, and maybe to the point of education too, is we have trained providers to be in this reactive system, and what they are is operators, right? Many providers historically have been trained to be operators. But operators are not what gets the predictive or preventive side done. What we need there is something different. We need them to be able to gain attention of the patient, and from attention you can drive compliance.
Yeah, you call it attention to compliance. I call it engagement to activation, but same principle.
It's the same principle there. We need for the provider to see that the prediction and the prevention is important,
Right.
and they need to communicate this to the patient in the way that the patient can receive it and become empowered to go on this healthcare journey and get better, right? The question, so within a sort of privatized model, right, within a control system, you can do this, right? We can hire nurse practitioners, we can, acquire different medical specialties and put them under one roof. We can all be on Epic. That does work in a closed system. But if we're dealing with a situation, where the patient has a care team, providers who are not maybe they're on Epic, maybe they're not, right? But they're not within, say, the PBS health system. They're somewhere else, maybe even distributed across different states and what have you. How do we get this information to them, right? If you have maybe even in your scenario, if you have a patient that comes in, you see this destruction, you break it down for the patient in a way that is not just their oral health and how to fix it, but their overall health and what has gone wrong. Now, how does that patient go on? How do you guys work with the other healthcare professionals? They have a primary care physician, they have a cardiologist, they have an orthopedist, they have a rheumatologist, whoever, who are not within the PDS ecosystem at all. Let's just say you don't know them currently. It's Dr. Smith and Dr. Joe Schmo, who you don't know at all right now. How do you collaborate with those external medical professionals to help this patient through their journey?
Yeah, we're a siloed healthcare country, so it's very, very hard. The chart reconciliation I was talking about with Epic is when they're in the Epic world, right? And 320 million patients in the United States have an Epic chart. So we're at an advantage there. But there's also the ability, the interoperability, right? That's there. So you can pull some of that information if your system is set up to do that. And you can get some of that information. The reality is if you're just asking the patient like something simple, like what meds are you on, they're going to get it wrong 95% of the time. The beauty, right? And the beauty of the interoperability is you can pull that in and hopefully help out the clinician so that no mistakes happen, right? And so it's important that we're really talking about the siloed care, but it's starting to converge. We're doing a conference here at Harvard in a couple months on Convergence, and it's happening. Two of my good friends are orthopedic surgeons. They don't do surgery without seeing the dentist for a check.
And they're not my dad and my brother.
And they are
both
my dad and my brother.
orthopedic surgeons. His dentist, mine is orthopedic.
And gynecologists now around. So we have a lot. Our workforce is 85% female. Yeah. Well, it just is what it is. But 85% female. 65% of our practice owners, are females. DSOs, you're talking about DSOs. DSOs are incredible for females. especially when they want to have kids and we can support their practice and all of that. And they love it. And that's why they're joining. We're in a female-dominated profession. We know that bad oral health can be a predictor of a preterm low-weight birth. Those of you that employ people know what one child that goes in the NICU costs us. It's about $1 million. Just one. We had one case a couple years ago of an employee had twins in NICU. $3 million hit to our organization. So we have gynecologists around that get this and are sending their patients to us for care way in advance. We train on talking for our clinicians to talk to their patients. Are you thinking of getting pregnant, or are you pregnant, so we can help them be healthier? And it's about engagement and activation into care.
So at the provider, again, I agree. At the provider level, it seems on the dental provider level, if they're using Epic, for example, they can pull in, they see a whole patient's medical account, right, history. They'll see if they've been to the hospital, see what medications they're on. They'll see, what happened at their last PCP visit potentially, or blood results.
Oh yeah,
pharmaceutical.
All that.
Right? So you on one side, we need to train dental clinicians to be more, if they have the access, to get the access, but then to be more aware of the medical information that can help them better treat this patient. And on the medical side, it's starting to happen too, because if we're in Epic and, or if we're sending them information, they are starting to be more aware, because they also look at the medical account. Oh, you were at the dentist last week. Oh, you're on amoxicillin right now, right? Oh, and you also take metformin. You're diabetic, even if somebody didn't code you in the last year, right? So we're starting to kind of see it on both sides. And I think this predictive element is maybe what gets us to convergence, right? That's maybe the bridge. I don't want to necessarily call it as the only bridge, but it's a space where, if the medical profession can see the value almost in the dental profession coming sort of upstream in the care journey, and then we've seen these things, we've documented these things. Maybe we don't have the power legally to diagnose certain things, but we've left the breadcrumbs essentially there for them, for the patient empowered with their information, and for the other medical professional on the other side looking in and saying, okay, I see this trail, they did the work for me. There's almost a point there, and I know we're separated for unnecessary reasons, but there's almost, and I want to encourage this audience, there's almost a piece where the dental profession is going to have to sort of swallow a little bit of pride, maybe, and take a step out into the space between first, the void, and do a little bit of the grunt work, a little bit of that heavier lifting, and sort of maybe deliver information right into the hands of the medical profession to show them. Do you agree with that?
Yeah. So I want to answer that question, then I'll give you my own thoughts on that. So my ideal would be, we all have monitors, screens, or you're looking at a phone or tablet, right?
Sure.
That somehow we can use the power of technology for a little robotic arm to come out of that screen and grab you by the neck and tell you what to look at, right? Yeah. To help clinicians be better. Now, with that, so let me back up. I would love nothing more than for us to move to one health plan for us. Now, I know a lot of people, I get a lot of hate mail on that one. One health plan. We have the data now to prove that oral health lowers the cost of patients' overall health care. I mean, we've all seen the studies out there, from whether it's Harvard or Mayo and others. There's so many studies out there. Just take diabetes. We did a recent internal one and looked at about 20,000 patients that were either pre-diabetic or diabetic. And then we looked at how many SRPs they had over that period of time and looked at the number they had. And then because of the power of Epic, we can go into Cosmos and look at all their other data.
What is Cosmos?
Cosmos is the best data lake of clinical information on the planet. And it's from Epic, okay? It's from Epic. All you data scientists in here. it's like it's a dream come true for you as a data scientist. So then we can go out and look at how many emergency room visits did those patients have? How many hospital visits intakes did they have? We are saving these employers millions and millions of dollars for their diabetic patients, and we're not fairly compensated for it at this time. You know, get me on a rant on insurance, any carriers in here. I mean, freaking, excuse the language, but insurance plans haven't changed in 40 years. We have some of the same plans that I started with in 1989 with my dad. We have to evolve that. It's insane. Why do we have a $1,500 max and a $50 deductible still? It's nuts.
Where the patient isn't necessarily clear on even what
not at all.
the prices are
I
transparent.
mean, maybe they bumped it up to 2,000. It's insane. And plus, let's be real here. There's no such thing as dental insurance. It's not insurance. It's a dental plan. They're outselling a panel for you to go get a discount on your care.
Yeah, I'll challenge everybody in the room to think of an insurer and, you know, even the broker as a facilitator.
That's
I think
all. That's all.
your point on the employer point is very important, right? We are saving them millions.
Millions.
They are not seeing it,
They don't see it.
and we're not getting compensated.
Correct.
There's a point in there that has to be worked on. Steve, I know we're running out of time. Before we do, I'd be remiss if I didn't ask you. We have a lot of changes on the horizon. CMS changes, they're on the move. CPT and coding changes. Brian this morning predicted interest coming down with new people in administration, midterms coming up in the middle of this year.
Yeah.
There's a lot of moving pieces. Where is oral health in your opinion? What is the future, near future, looking like from your perspective?
Near future, even 20 years out. I wish I was 20 years younger and just getting in this profession. It is so right. We weren't in the overall healthcare world of helping people out. We weren't even on the hockey stick. Do we have Canadians in here? Did you guys win or lose to Chet? You won? Oh, shit. I want US, and someday we're gonna meet. I'm a huge hockey fan.
And your kids play hockey.
And my kids play hockey. Well, they don't anymore now. They coach hockey.
There you go.
They weren't good. They weren't good enough to keep.
You lose less teeth that way.
Yeah. So where was I?
The future.
The future. What an exciting time. I mean, the power of AI, the technology. I've had to add to my team to review all the technologies that are out there, and we talk all the time. And it's crazy. I was just in Europe last week looking at new technologies in Germany and Liechtenstein and Switzerland, and it's a worldwide space. What an amazing opportunity. And patients, we're at the highest level of what we call opportunities per day per clinician in my 36 years. Patients want providers. They want oral health. And they want to come in and take care of their mouth. So it's just such an incredible time to be in primary care, because I think we have to converge these. We have to break down those silos. So it's such an exciting time.
Let's end on that. It's an incredible time to be in primary care. Everybody, please help me thank Steve Thorne.
Yeah.